Hi, everyone. A warm welcome to everyone joining us today, both seasoned members and new members of our online community. I am Dion Gessink. I'm a professor of epidemiology and the acting Associate Dean of Academic Affairs at the Dalla Lana School of Public Health. Last week, we hosted our first COVID webinar, and there was great conversation online. So please feel free to continue the conversation on our YouTube page. And if you're on Twitter, please use the hashtag COVID-19 DLSPH. As many of you know, the Dalla Lana School of Public Health is the top school of public health in Canada and one of the top in the world. So many of our faculty, students, and staff are actively involved in the COVID response and working quickly to provide reliable evidence so government officials can make informed decisions about what actions to take to protect Canadians. Clearly, there's a lot of ethical issues that emerge around possible courses of action, and our team at the Joint Centre for Bioethics is currently leading the ethics table of the Ontario COVID Health Systems response. The ethics table comprises 17 bioethicists from across Ontario, including Jennifer Gibson, who is the Centre's director and the table's co-chair, Max Smith, who is also the co-chair, Sally Bean, and Nancy Odrusek. Today's moderator, Ross Upshur, and panelist, Allison Thompson. The table is currently providing guidance and framework on decisions pertaining to public health measures, resource allocation like personal protective equipment, critical care triage, and long-term care policy issues during the pandemic. The Joint Center for Bioethics faculty members are also working closely with the World Health Organization on the global response, which includes consultation on ethics and artificial intelligence in the COVID response. Many of you may have neighbors or family members wondering why they have to sacrifice their movement and social and economic interactions for others. It's important for us to remember what is at stake and who we can help and how. Today, we will explore the reasoning behind these restrictive measures from those who study these issues every day. If you get nothing else from today, please know that your actions have an impact on the people who surround you and our community. So I'd like to introduce Ross Upshur, who's going to moderate our session today. Ross is a professor and chair in clinical public health at the Dalla Lana School of Public Health. Dr. Upshur has been active on advisory boards for the International Joint Commission, Doctors Without Borders, several medical journals, and is chairing the ethics working group for the World Health Organization in the current COVID-19 epidemic. He played a similar role in the 2014 to 16 West Africa Ebola outbreak and the 2009 H1N1 outbreak. So thank you, Ross, for moderating today.
Thank you, Dion. First, I'd like to welcome everybody to our symposium. I hope everyone is safe and well and keeping sane during these extraordinary times. Today's focus is going to talk about restrictive measures, and we've kind of got a whole new nomenclature: quarantine, self-isolation, lockdown. There's all sorts of new things that are happening, and it's extraordinary because it's not just happening locally, it's happening globally. We are very fortunate to be joined by some of the leading scholars, not just in Canada, but in the world on some of these topics. And they also happen to be some of my favorite colleagues. So I'm very delighted that they were able to take time out. I know some of them are very much active in the COVID response, and they've generously given their time to spend with us this afternoon. So I'm going to introduce them first, and then we're going to open up. We have a series of questions. As you know, you can send questions to our moderator, who's Francois Makanda, who's in the background and has done absolutely fabulous work in helping to organize these series. So I think she needs a special vote of thanks for all of her efforts. So I'm going to go with the first. I'd like to introduce Trudeau Lemons, who's a professor and the Skoll Chair in Health Law and Policy at the Faculty of Law at the University of Toronto, who's also cross-appointed with the Dalla Lana School of Public Health and the Joint Centre for Bioethics. Professor Allison Thompson, who is an associate professor in the Leslie Dan Faculty of Pharmacy and also at the Dalla Lana School of Public Health and a member of the Joint Centre for Bioethics. She has quite extensive experience in thinking about issues with respect to ethics and epidemics. She was part of our Canadian program of research on ethics in a pandemic that we had back in the around the H1N1 time, and has published extensively on these topics. We're also happy to be joined by Christopher Ruddy. Christopher Christopher Ruddy is Canada's preeminent public health historian. He's a member of the Division of Clinical Public Health at the Dalalana School of Public Health. He has done extensive work and historical research on Canada, on the history of Canadian public health, including, I think his doctoral dissertation was on the history of the polio epidemic in Canada. Jeff Kwong is with us. Jeff is one of the world's leading health services influenza and infectious disease epidemiologist. He's the program leader of populations and public health program at ICES, a scientist at Public Health Ontario, and a professor in the Department of Family and Community Medicine with a cross appointment here at the Dalalana School of Public Health, and is a public health physician and specialist. And last but not least, we have with us Anna Banerjee. And Anna is an associate professor here at the Dalalana School of Public Health, but is a pediatric infectious and tropical disease specialist with an MPH in international health from the Harvard School of Public Health. She's currently chair of the Indigenous Health Conference and the North American Refugee Health Conference. She's been active in working in SARS and was at that time, yeah, you were an associate medical officer of health with the City of Toronto, and has also been working with Syrian refugees and studying lower respiratory tract infections in Inuit children for 25 years. So I cannot think of a better group of people to help us think through some of the ethical and legal questions. But we're going to start first with history. Many of us are sort of unfamiliar with the use of these restrictive measures. We may have a vague memory of their employment during SARS, but I'm going to turn first to Chris to give us a little bit of a background on the history of quarantine, what it means, where it came from, how it's been employed. Then we're going to move to sort of the evolution towards the Quarantine Act. And then I'm going to ask Trudeau and Chris to talk a little bit about the Quarantine Act, which has also been in the news. So without further ado, over to you, Chris.
Hello. Hello, everybody. Well, quarantine goes back quite a ways, and you can go way back to Middle Ages with the plague. Just the whole idea of trying to restrict people's movements. There's a whole history that I've got time to get into all the details of it. But the last time we were in a situation where it was a global kind of situation was with Ebola in 2014-16, which I think Ross was involved with particularly. But that's when we actually saw, sort of post-SARS, a global kind of, not a crisis like we're in now, but a real concern about what was going to happen, and a real reaction from, especially on West Africa, the countries Sierra Leone and Liberia, and anyway, there's major countries in the West Africa, and what they were doing there locally in different ways, different levels of quarantine imposed on their communities, whether or not they actually had Ebola, and the reactions to that. And there's also an important American and Canadian component to that, in trying to protect or prevent Ebola from coming over here. And they actually did come over into the States. There were some cases that came over, and the way the Americans responded to that, and actually how Canadians responded to it as well. We actually restricted the border to people from West Africa, or people that had visas being considered, and they were sort of put on hold for a while. So that was actually quite restrictive. But in terms of quarantine, at that time, from what I've understand about it, is they didn't actually do a lot. I mean, they just sort of created more problems than they prevented. Doctors Without Borders made that kind of comment afterwards, and seeing that it actually drove people into the underground and trying to avoid things. And that, in that particular context, it was a very difficult thing for it to be effective. And then, SARS is the other example that comes to mind, I guess, for most of us, because most of us lived through it. But the idea of quarantine and what happened in Toronto really sort of demonstrated in some sense that we overreacted in that way. Quarantine hadn't been applied to in Canada for quite a while before that. And so it was a big issue when they were discussing actually imposing quarantine on contacts of cases. On a fairly large scale relative to at the time, but the results of that were fairly limited, from what I understand, in terms of actually limiting any kind of community spread, because actually SARS didn't really have a lot of threat of community spread. Looking back on it, it never got into communities. And so the reaction, the imposition of quarantine was very much tied to the emergency of the situation and trying to cope with it. Because the thing with SARS, we kind of went into it being unprepared for something like this to happen. And so there was a lot of, and the fact it entered right to the heart of our system in the hospitals. And that's where it was most deadly, affecting hospital workers and trying to control that. And that was a real focus of the situation with that. So
Great. So Trudeau, we're now in the situation where legal instruments like the Quarantine Act are being used for the first time in some time. Do you want to just give the audience a snapshot of what the Quarantine Act is and what its intended goals are and how it might serve public health purposes? And then we'll come back to proportionality and effectiveness of quarantine as we evolve our discussion.
Yeah, so maybe first a comment that most of the people who are listening to this conversation and are living in Ontario are more affected by the Emergency Management and Civil Protection Act of Ontario. So the Federal Quarantine Act is focused on federal jurisdiction. The full name is Act to Prevent the Intro and Spread of Communicable Diseases. And really, if you look through the Act, what the provisions are, they focus on measures that allow the federal government in its area of jurisdiction to help control and prevent the spread of communicable diseases which have come primarily through travel. So if you go through I can simply mention very briefly some of the broad powers that the Quarantine Act gives, which was also perhaps interesting to mention, updated in the wake of SARS. So you have measures with respect to the establishment of a public health infrastructure, to set up quarantine stations, designate facilities as quarantine stations. It has provisions with respect to designating people, public health officers, screening officers, and so on. It has provisions with respect to so-called conveyances, which comprises everything that involves transportation, airlines, boats, and so on, and creates obligations and measures to enforce obligations for these transporters. It also has then measures with respect to human cadavers and body parts, which fortunately has not been so important yet, but which may become also important in the context of the crisis. And then there are general provisions with respect to the powers of the officers to enforce quarantine measures, to stop and inspect cargoes, data gathering, also very important provision. There are also provisions with respect to that allow the federal government to enact emergency orders, which it has rarely needed to do, but has been done now, and a number of regulatory powers for the federal government to enforce public health. I would say that kind of gives an overview of the general powers under the Quarantine Act. I may mention here simply that indeed there are also principles mentioned under the Quarantine Act that relates to proportionality, reasonableness of the measures, and so on, judicial control of some enforcement measures, so which we will be discussing later. And then finally, maybe simply to mention, not unimportant, the possibility to impose penalties, which has been emphasized by the Minister of Health. It depends on what violation, but for contraventions, it goes up to in some cases $750,000 or less than 6 months in prison. But if for some other measures that really create a serious risk of death or imminent harm, you can actually have penalties of up to $1 million and under 3 years in prison. So serious powers to the federal government to enforce some of these provisions.
Thank you, Trudeau. So now we're going to move into, I'm going to ask Anna and then maybe Jeff, because he's also has public health preventive medicine training. Anna, can you tell us a little bit about when it's legitimate to and required to institute these restrictions? And how is it that public health authorities decide which measures to employ to control a disease? You need to unmute, Anna.
Okay, sorry. The Public Health Act and quarantine has been there for about 150 years. And it's when, and it's legally enforceable when we feel that the risk to public safety outweighs individual rights. And so when someone has a condition that they could potentially impact other people, then we implement it. So we've implemented it in historically with smallpox, the plague, but even now on a regular basis, you would implement it for someone who has active pulmonary tuberculosis that fails to have treatment or be in isolation. And so in this situation with COVID-19, when people are not, this is a situation where there is a risk to public safety, where there is a risk of casualties, fatalities, suffering, we can implement that. And we basically start with the least consequential or least restrictive measures. But then if people don't pay attention to that, then you increase it. So if someone is not paying attention to the quarantine, they can be fined or put in jail. And this does happen and has happened with other infectious diseases.
Thanks. So Jeff, this would be broadly under what I would call the mandate mission of health protection that public health serves. Public health is in the institutional sense, is probably the only group or only sector in the health system that has these legislative powers to enforce or to issue these orders. Any sense from your side as a communicable disease epidemiologist about when these should be triggered?
Well, yeah, definitely, when there's a communicable condition, we need to consider this. And this is, a condition where, you have a broad spectrum of illness, right? So it can cause severe illness, but it can also cause mild illness. And I think that's where it's particularly tricky. And we have to use these quarantine measures because some people may be transmissible before they even have symptoms, or maybe they may be completely asymptomatic over the course of the illness. So that's why I think the quarantine measures are especially important. And that's why we've even extended the recommendations that everyone should be engaging in physical distancing, because it's hard to track down every single case at this point.
So clearly you need a harm, a threat, something that's person to person. So an infectious disease that, say, isn't transmissible between persons, like, for example, after 9/11, there was the anthrax scare, and there was no sense of ever employing restrictive measures for that because it wasn't possible of being spread from person to person. And as Anna mentioned, there's this notion of least restrictive to more restrictive, sort of a progressive move through restrictions. And each and every one of these requires a trade-off between individual rights and public good, which of course raises very significant ethical issues. So Ali, I wonder if you could walk us through some of those issues and how they're balanced and what sort of principles or considerations we might need to think through.
Sure. So I think that, often we frame this conversation as an issue which pits individual liberty against the need to protect the public from harm. And I think our research that we did back in the day, 10 years ago or so, also identified the need to create the conditions for people to be able to comply with these measures. So it's not reasonable to ask someone who doesn't have a home to quarantine themselves. So there's this sense that there are reciprocal obligations on the part of the state to provide the ability to comply with a measure which is going to restrict liberty. But there's also a sort of mid-level issue here about the need for communities to be able to have some input into deciding what is actually appropriate in terms of restrictive measures. So for some communities, it may be acceptable to allow them to hold a funeral, for example, because that value for the community trumps the need to restrict movement to protect the public from harm. And that's not necessarily pitting individual rights against the public's health more broadly. It's sort of a community level issue where we need to think about what the other social costs are besides death and mortality, morbidity. Are there other values that come into play here? Like, do we need to think about, what is the impact of not allowing a priest into a hospital to give last rites to a dying patient? We need to think about what's the impact of not allowing people to have the ability to have a funeral for their loved ones. And so these are complicating the whole conversation. So I just wanted to add some nuance to show that it's not just a matter of the individual versus the public. There are these other considerations we can inject into the conversation.
Thanks, Ali. So this actually raises the issue of certain populations having barriers or obstacles to the ability to comply with some of those restrictive measures. We can think of certain populations, and I'm going to ask Jeff to speak to homeless and sheltered populations, and then Anna to speak to issues around Indigenous and refugee populations. Then I'm going to come back to Chris for some observations on how these measures have been used selectively in the past to sort of put pressure on particular groups. So Jeff?
Yeah, so I mean, I think there's a lot of people out there who are complaining about needing to stay at home for an extended period of time, but at least you're fortunate that you have a home to stay in. Think about all the homeless people who are routinely living in shelters. Those conditions are very crowded. And so how do we ensure the physical distancing measures, and how do we ensure that they're safe and not potentially infecting others? So I see, some communities have been, renting out hotels so that they can house, some of these homeless individuals. But then you have to think about some of the practical things, such as like, what if they are smokers? How will they smoke? If they're, confined to a hotel room. And so I think these are some of the things that we need to think about. We need to provide them with access to food and medications, as well as psychosocial support, because being alone all the time is quite stressful for anybody, let alone somebody who may have issues with mental health. So these are just some of the things that we really need to think about, and I'm sure all the people who are working with this population are actively working in this area. So I'll turn it over to Anna.
Okay.
Anna?
Thank you. So as we don't have refugee camps here, but refugee camps internationally, I don't really know how they do quarantine or self-isolation when they don't have the basics in healthcare, and they don't have basic sanitation. But in Canada, the refugee claimants, the ones that would be crossing the international border, that has been blocked, I think a couple of weeks ago, by the government, and the refugee claimants are being turned around. The refugees that are here, even government-assisted refugees, since the quarantine was in place, because we're banning international travel, refugees are not coming into Canada. But the refugees that are here, refugee claimants, are staying in hotels. And again, that's you can try to quarantine the hotel, but how do you keep children in a one-room hotel not playing with each other? So those are a lot of challenges that go in there with the refugee claimants and the refugees that are currently in shelters. Just the same issues that you consider with homelessness. Now, with Indigenous populations, there are many Indigenous populations that are remote, that are fly-in, and there are some significant issues there. For example, you have severe overcrowding in a lot of these communities. You have 20 people living in a one-bedroom house. How do you isolate and quarantine those people? Like, how do you take people out and make sure that the people who are vulnerable are safe? I mean, some of the things we can do, I think what Alison was saying is we need to enable people to do the quarantine. We need to enable people to do the right thing. So, and I think that may mean having exterior help coming in, whether it's, the military, there's a whole bunch of ideas because of trauma, and do we really want the military to come into these remote indigenous communities? There's a lot, but I think some kind of help to help these communities, so you can start thinking about how you're going to separate out the sick from the well, and how you're going to rapidly test these people, and how do you enable these communities where there's so much overcrowding to maintain some kind of quarantine. And it might just be community quarantine, where you restrict all unnecessary travel into a community to try to delay the virus from getting there.
Thanks. So that raises an interesting historical point. So one of my colleagues at McMaster, Ann Herring, who's a social anthropologist, did some interesting studies looking at mortality along the trap lines in the far north during the 1918 pandemic. And those families that came into the community, the trading post, went back and suffered a high mortality because of transmission. Those that didn't come in had no higher than expected mortality. So we know it's another indirect way, because we know pathophysiologically and epidemiologically that if you do not connect with somebody who has the disease, you're not going to get it. So Chris, I want to come back to you. Quarantine had and restrictive measures had earned an unfavorable reputation in public health practice, largely through events in the 19th and early 20th century, where restrictive measures were used selectively against particular populations. So I'd like you to speak about that for a few minutes, and then I want to come to Trudeau to ask Trudeau, what are the kind of legal requirements and procedures that need to be in place to ensure that there's no such abuses of power now that we're in emergency power situation in the current situation. So over to you, Chris, and then to Trudeau.
Okay, well, the original Quarantine Act goes back to the mid-19th century, actually, late 50s, pre-Confederation, and its actual basis was to restrict the inflow of immigrants from Europe, basically. So that was where the filter was. The focus was on keeping Canada more pure, I guess. I mean, it was kind of really tied together with those sort of ideologies of the time. You mentioned also the Inuit and the northern impacts of quarantine. Actually, the largest quarantine in Canadian history was in the Eastern Arctic in 1949, when polio struck up there. And it was a huge quarantine over 40,000 square kilometers involving the whole Western Arctic. And it was really a very serious situation at that time. Polio was not expected to be up there in the middle of the winter. And so there was a whole situation that came out of that, and how do you manage polio in that context? So that's one side of it. But in terms of the Quarantine Act, it was designed to be to keep people from coming in, basically, and it didn't really change until SARS. And a lot of the stuff that was discussed earlier about the Quarantine Act today came out of the post-SARS experience, to rewrite the whole act and apply more rigorous provisions within it than had been there before. So I guess yeah. I mean, it's a big topic. Yeah.
So Trudeau, can you speak to sort of the legal procedural protections that are required to be in place for restrictive measures to sort of be acceptable in terms of our charter, et cetera, et cetera? And you need to unmute, Trudeau.
Sorry about that. So in the Quarantine Act itself, obviously, there are some provisions with respect to procedure. So some procedural procedures in relation to judicial review of the more extreme measures, control of individuals. So there are some restrictions already in what can be done and what can be imposed on individuals in the Quarantine Act itself. And overall, I would say we have to look at some of the principles that I already mentioned that are embedded in the Quarantine Act, that you also see embedded in documents like the Canadian Charter. So the Quarantine Act could be submitted to charter review. I would emphasize here that we actually often wrongly presume that the pandemic style, or the review of pandemic style legislation, would be so substantially different from the review that we already have in place. So we already have within the charter, and there is an extensive jurisprudence that looks at how we have to balance individual rights versus collective interest. We do that already. I would say personally, I think that sometimes in Canadian jurisprudence we have emphasized too often individual rights, with sometimes paying short shrift to some of the collective rights. I think about the Shauli decision about the design of our healthcare system, but generally we do accept that the individual rights can be restricted or limited for the purpose of collective interest and interest of others. And there we have to look then at the Charter Section 1 review of legislation, which says that legislation has to be, or limitations of individual rights have to be reasonably necessary, have to be rationally connected to a particular acceptable goal. Here, obviously, the protection of public health and the well-being of our society in general, that the measures have to be as minimally impairing as necessary for the goal that we try to achieve, and that they're proportional. And there I would say we have to look at or take into consideration the fact that we have to some extent limited evidence about what works best. We are trying, and I think the legal system, the courts would be flexible with respect to reasonable measures that are being put forward, even in the absence of very clear evidence that they inevitably work. So we're dealing with a very unique situation where we're gathering data on the ground. But obviously, we will have to show, if we restrict individual liberties, that these restrictions are really necessary to achieve a goal. And I'm thinking here particularly about some of the things that Alison also pointed out, and some of the other speakers, about vulnerable populations that may have particular problems with implementing, say, quarantine measures. I'm thinking also about the fact that in mental health institutions, the enforcement of some of these quarantine measures may be particularly challenging for people who have a lack of understanding of actually what is going on. So our legal system will require also that we make additional efforts to make sure that already disadvantaged populations, I'm thinking about the prison system, the mental health system, indigenous populations, people with disabilities, are receiving additional care and additional attention to really ensure that we're treating people not just formally equally, but also substantially equally.
Thanks, Trudeau. So in my thinking about the imposition of some sort of restrictive measure, we've covered off 3 of the 4 justificatory conditions by my thinking. Clearly, the condition of harm is being met. The COVID-19, SARS coronavirus 2, is not a nice pathogen to have running loose in a community. We've talked about proportionality and the least restrictive means to control the threat. We've talked about reciprocity, which is the obligation on those requiring people to live under these conditions to be supported. And we've started to see some legislation. We've had some discussion about some of the populations that might have particular difficulty with this. The last condition is around issues of transparency, communication, and what I would call basically the sort of ideal speech and ideal communications. Ali, I'm going to ask you, because I know you wrote a paper for the World Health Organization on communications in pandemics. And then I'm going to come back to Anna and Jeff to see if they have any particular insights from a public health point of view about how and what to communicate to the public, how much knowledge should be communicated. And then after that, we're going to get close to opening up for conversation. So Ali, over to you.
Thanks, Ross. I guess I should start by saying that I think that communications are an essential part to outbreak response, and they're not a sort of peripheral consideration, because we know that people, when they understand the rationale behind restrictive measures, are generally fairly compliant. And the need to be transparent and trustworthy as public health actors who are requesting people to limit their individual liberty is absolutely vital. And so we've talked a lot about the sort of stick approach and the powers that the state has to use the stick to get people to comply. But obviously, it's much more ethical and much more preferable for people to comply voluntarily. And so, what does that carrot look like? Well, when people understand the rationale behind these decisions, they're much more likely to comply, and they're not going to resist complying when they're being asked voluntarily. So that's always going to be preferable. And so the link between communications, transparency, and trust is really crucial here. And the public needs to be able to place their trust in public health, and that requires transparency for anybody doing outbreak communications. And the only time it's really appropriate to withhold information from the public is when there's a compelling reason to do so, say for national security, say a police investigation that's underway, or perhaps the undue stigmatization of certain ethnic groups or other groups of people who may be made vulnerable by revealing that information. So I think that in this particular outbreak, we have seen so much information. There's people who are calling this the infodemic. It's very hard for people to know how to place their trust and who to believe and what to believe. So this has been a real challenge in this outbreak. And I think that, as we go forward, there are going to be a lot of lessons to learn about the need for transparency and trust in terms of getting people to comply with these measures.
Anna, from your experience in working in public health and communicating with the public, there's often pressure for more information than I think public health would be willing to give out, like the individual names. I remember during SARS, there was considerable pressure to divulge the individual identity of somebody who might have been on a GO train. How do you see this playing out, and what sort of special challenges do public health decision makers face when talking about how to meet some of these standards of transparency that Ali has just articulated?
So I agree with everything that Ali was saying, but I think that we also have to we have legal obligations to protect privacy, unless it's an extreme situation, like there was an individual who had HIV and they gave the identity. But here, having individuals named does not seek any public good, really. And so I think that we need to be transparent. We need the buy-in. We need people to cooperate, because they believe that it's the right thing to do, that staying home saves lives. But I think that there are things like names that we really need to uphold as well.
Jeff, do you want to add anything to this?
I mean, I'll just talk about some of the practical things. Like, it's one thing to, we want to reach as many people as possible. Obviously, everybody, ideally everybody. And sometimes it may involve like translating messages into different languages so that we can, get the message across to everyone. So I think that's an important thing. We can't just assume. And also the way that people are consuming their media now is different. And so I think we really need to use as many channels as possible to get the word out to everyone.
Okay, so we're starting to get some questions from the crowd. One, before we move to those, there's just one last question I'd like to ask the panel. So we're living in an era of innovation. There is a great enthusiasm for using everybody's favorite personal device to use for public health purposes. So how far do you think it would be appropriate to violate privacy to use mobile devices for the collection and transmission of information with respect to people who may or may not be cases or may not be contacts? Does anybody, and this is going to lead to the first question that comes from the crowd. Does anybody have a strong sense of whether this should be something that we should pursue, or whether there's particular hazards in going down that route?
I would say, if you look at privacy law, embedded in privacy are fair information principles. So I would say we really have to know whether this type of collection of information is necessary to achieve the goal of protecting public health. So I would say a first requirement will be, is it absolutely necessary? At the same time, it's interesting how people already share, and I'm part of that, a lot of their health information or physical movements via Strava and other tools, and are willing to do so for very wide purposes among themselves. So if it really enables public health measures that are targeting specific situations, I would say in exceptional circumstances, it may have to be considered. I would rely on the experts there to say when it would be necessary and for what purposes. I would also say that it's very important to keep in mind that we want to make sure that some of these measures are only implemented in the context of this very exceptional procedure. So there is a serious concern that things that we start normalizing now in the pandemic will stay on the books and will become a tool for law enforcement, for other regulatory agencies to with invasion of our privacy. So these are my two comments. I would say, if absolutely necessary, but certainly with restrictions that it should only be in the context of the pandemic for the goal of preventing spreading of the disease.
Does any of the other panelists want to chime in on that? Jeff?
Yeah, I'd like to speak a little bit about that. I mean, I think these apps are being used in countries in Asia where, you know, it's voluntary to sign up for these apps. And I think obviously we would want to make it voluntary for people to use these apps. But I think they're effective because, you know, they help in contact tracing, right? So as it is right now, you know, we're having challenges testing everyone who, you know, wants to be tested or may need to be tested. And then there's delays in like getting the results. And then public health is having a hard time keeping up with the demand for contact tracing. So I think this might help with that, where, you know, imagine your phone alerts you saying that, oh, like a few days ago, you were in an area where there was a, you know, confirmed case and you spent more than 30 minutes there. You may have been in close proximity with this person. Obviously that won't be happening now because we're all doing our physical distancing. We have to think about, you know, how are we going to start relaxing some of these physical distancing measures? You know, we have to have an open mind and think of more strategies beyond just the status quo.
Great, thanks. So I'm going to open up to the questions are coming in fast and furious now. So the first one relates to the appropriate punishment for breaking quarantine. And I'm going to frame that, I mentioned in our, when we were discussing before we opened the session, that when we did a survey of Canadians around H1N1, asking them what they thought a violation of a quarantine order was like. Was it like running a stop sign, speeding, physical assault, or manslaughter? 50% of Canadian respondents in a random sample survey nationally responded that violating a quarantine order was like manslaughter, and 29% like physical assault. So 79% of the Canadians at that time believed that violating a quarantine order was essentially equivalent to a felony. So what punishments should be appropriate for breaking quarantine? In some countries, the breaking the lockdown is punishable by jail time. Where should the law be drawn in terms of punishment? Are warnings and fines enough? Is jail time too much? So that's the first question that's come in from the audience. Who wants to respond to that first?
I would, if you...
Allie, go ahead, yes.
Okay, well, I mean, I think it obviously depends to some extent on the circumstances. If it's somebody who's homeless and can't comply, obviously that would a sort of criminalization of that behavior would be inappropriate. I do want to ask, though, you know, what's the end game here? Because if we come down very hard on people for breaking quarantine, we have to think about the long-term consequences to the public's trust. You know, so is this supposed to function as a deterrent? Are we actually just going to take someone and put them into a quarantine facility against their will, which we do now for people who don't comply with tuberculosis treatment if they have active disease? You know, so the criminalization of this kind of behavior is, I think, incredibly ethically problematic. We've seen the huge stigmatization of people with HIV who have been criminalized for spreading the disease. And again, what's the significance of people's intention here? So in those particular cases for HIV, there was some intent or sort of reckless behavior. If you're going out to get milk because your family's starving and you're breaking quarantine, that matters too. So I think it's very hard to say in general what the consequence should be, but we need to think about, the long-term implications for public trust, the role of this as a deterrent, and these issues around how can people comply.
Trudeau, did you want to speak to that?
All that, and as well, it depends. Is it someone like all of us?
Yes, no, so I was simply to say that I agree with Alison. So there is a concern about the criminalization of behavior, particularly for public health related purposes. And I think all of us here on the panel would agree that putting people now in prison is the opposite of what we should be doing, because the prisons are a very serious concern for the spread of the disease. So prison penalties, maybe even future penalties. I mean, people would say, well, let's impose future prison penalties are not the right answer. But obviously, we want to convey the message that some of these measures are very important and have to be implemented. I would emphasize also, as Alison points out, if we criminalize this, it particularly will impact on people who are already disadvantaged, are at higher risk of infection. I'm thinking about the homeless people, thinking about people who may not fully comprehend the measures that are being imposed. So educational measures are key. Threat of penalties in some circumstances seem appropriate. If you see people conveying in parks and ignoring what public health officials are saying, I would say we have to be really careful about the criminalization of this behavior.
So would, for example, issuing a ticket or a fine for this sort of activity be proportional? I think the case of imprisoning people makes probably little sense, given that you're taking. But what would be in the minds of this panel appropriate remonstrance for failing to take behaviors that put others at potential risk?
I was just going to say the problem with the whole issue of quarantine, in a sense, in a public sense, is that people don't really understand what it is. I mean, we don't deal with this situation all that often, especially on this scale. And so you have to understand what their knowledge base is of the actual quarantine, or actually understanding what's going on around them. I mean, that's a very fundamental part of this, I think. And if there's a willful ignorance, or if they do know what they're doing and they're actually doing it anyway, that's the real problem. And they go to their way to cause harm, to neglect what they already know. So there is a bit of a wiggle room in the sense of ignorance, potentially, or just not really understanding what's happening and dealing with the more pressing problems, like you mentioned, going out to get food or milk, and really not getting a sense. Because there's also just an understanding of the disease we're dealing with and how it's changed over the course of the pandemic. And people are thinking, oh, I'm young and not really a problem. And then also they're not really connected to the news that much. I mean, they're very focused on Netflix and their own particular worlds and so on. And people aren't really keeping up with the news. I mean, we have a flood of information, but some people actively tune it out and don't really get a sense of the nuances of how things have changed, and how they're realizing that even if you're not symptomatic, you're a threat potentially, not only to yourself, but other people. And that message is hard to get through to people. And so to be overly harsh on people for working quarantine potentially, especially if they're not sick necessarily. I mean, if they actually are sick and they know they're sick and they've been tested and all that kind of thing, that's a different thing. But for the general population, to break the being at home kind of ideas and so forth, just because they're out playing basketball or something. If there's a willful ignorance, then that's a problem. If they don't really understand it, take it as a teaching moment. Perhaps that might be a way to approach it. Because you're not really doing much good by being overly harsh in these sort of situations, I don't think either.
Yeah, that's a very good point, Chris. This is complete news to our culture. The notion that we would have to take personal sacrifices in order to control a pathogen, and it's probably not the case that everyone is spending 24/7 reading about COVID as some of us are. Now, this leads to the second question that was raised. And maybe I'll hand this over to Jeff and Anna. In the absence of mass testing, how is it actually justifiable to isolate healthy people?
Well, I think in this case, it's exactly because we don't have mass testing that we have to do this. We don't know who has the infection or not. And so, I mean, this is really kind of like a measure to try to buy us time to have everyone doing social distancing so that we can hopefully have those who are already infected, have their illness play out, and then they'll recover and not infect more people. Because this is really the only measure we have right now. We don't have a vaccine, we don't have effective therapies, and we don't know who actually has the infection because we don't have the capacity to test every single person, or even the ones who have symptoms, we don't have enough testing capacity to test every single one of them. So,
yeah, and if they believe that about 20% of the people that are transmitting are actually asymptomatic, then anyone could be transmitting. And so, it seems that the physical distancing that we have right now probably is working, as Toronto being a very large city with a lot of international travel. And we haven't seen the kind of spike that we've seen in Italy or New York and that. So it is one of the tools that we have right now to try to prevent this from rapidly escalating.
Right. Thanks. So the next question is, what are the ethical concerns around a total immediate lockdown, such as what happened in Wuhan, versus the kind of gradual restrictions that have been employed in Canada? The questioner says it seems like the increasing level of restriction in Ontario is in response to increases in reported cases, yet those cases are actually reflecting events that took place several days, maybe 10 days to 2 weeks earlier. Should we be being more aggressive now in order to bring the epidemic under control?
do you want me to jump in there, Ross?
Yeah, Jeff, you're the epi guy here.
I'm not sure that that there's the increase in the restrictiveness because of more and more cases, or if it's more because there's, I think there's realization that people aren't following the restrictions. And so, I mean, I think, we try, education, we try encouragement, and then we have to go to enforcement if we're seeing that education and encouragement are not working. And so I think that's what's driving it. I mean, I think we knew there were going to be more and more cases. It's just that we weren't expecting perhaps that people would not be abiding by their requests to practice the physical distancing measures.
Okay, so
can I just
go ahead, Ellie. Yeah.
I mean, I guess it's a question about the ethical difference between a suppression versus a mitigation strategy, right? So a suppression strategy is probably more effective, but it's far more restrictive. And at this point in time, we don't really know how long that would have to take place for, and the likelihood of some kind of rebound effect after you remove the suppression strategy is quite likely, I think. So, but on the other hand, a mitigation strategy is going to accept a certain number of deaths, that mitigation strategy, which is much less restrictive and sort of more weighted towards individual liberty, there will be more deaths. The healthcare system will be overwhelmed. So it's a bit of a trade-off between, in the absence of good data, which is going to be most effective, but then also how restrictive ought we to be, given that we don't know which strategy is best here.
So here's there's two more questions I'd like to raise from the audience. So one is to provide some insight on the ethics of asking individuals who are retired healthcare workers to return to work to support the fight against coronavirus when we know that age is a very powerful risk factor, and they might be better off remaining at home in quarantine. Anybody want to take that one on?
I'd be happy to jump in there.
Yeah. Okay. So Jeff and then Anna.
Okay. Yeah. I mean, there's lots of things that retired healthcare workers could be doing. For like instance, physicians and nurses. They could be, helping to answer questions on hotlines. They can be helping with contact tracing efforts. They can be helping to manage patients virtually. So a lot of the practicing physicians right now have switched over to phone calls, emails, or video calls with patients. And some of these clinicians could come back and help with those tasks as well. So, I mean, I absolutely think it's, very ethical to make the request that they could come back to help out, at least ease some of the load on the currently practicing clinicians. And those ones can go work doing the, physical, like in-person patient care.
Anna, did you want to jump in?
I was just saying it was desperation, but I think that there are a lot of things that retired or people that are not working could help in, like you said, virtually. But I think that if someone falls in the high risk category, if someone's elderly, they have underlying health conditions, it probably wouldn't be a good place to put them on front line, exposing them to coronavirus.
Excellent. So we've got about 5 minutes left and still a large number of questions. So first, let me apologize to members in the audience whose question we didn't get to. So the last question I'm going to raise is about, we're not going to have a vaccine for 1 to 2 years. How do we ensure that people aren't having their lives interrupted and freedom restricted for this whole time period? What long-term strategies are there to think about in terms of the long term? Anybody got a crystal ball and a magic wand?
Yeah, I mean, I think we need to look to countries where they have had a lot of success in managing this virus. So places like Singapore, Taiwan, Hong Kong, South Korea. I think they've used a lot of different measures at the same time, right? So, a lot of availability of testing, aggressive and rigorous contact tracing, use of face masks, and very rigorous hand hygiene. So I think all of these things should be on the table, for us to consider, because I think we're being optimistic, for a vaccine in 1 to 2 years. Even it may take longer than that, given that if you look at all the vaccines we have against respiratory viruses, there's just influenza, and that's not a very good vaccine. Either. And we've been trying to develop an RSV vaccine for decades and have yet to develop one. So, not to be overly pessimistic, I know a lot of very smart people are working on, as hard as possible to develop a vaccine against the new coronavirus. But I think we just have to be prepared for the possibility that there may not be a vaccine, and we're going to have to use alternative measures to mitigate the impact of this while trying to go back to as normal life as possible.
Yes. Well, Jeff is. Oh, go ahead, Anna.
One of the things, hypothetically, I was thinking about this. For example, for healthcare workers, if once we had access, serological testing, and so we know a lot of people get coronavirus and they don't actually have symptoms. So if, like, for example, healthcare providers had monthly testing, then we'd know who's immune, who's not immune, and once you have all those immune people, then they're theoretically safe to go in. So I think if we can gradually increase the number of people that we know are protected to go and do some of this work, then we can try to protect the people who are not immune. So I think that's a strategy I was thinking about.
Yeah, so I completely agree. I think basic science of immunology and protective immunity and serology levels will be very helpful if this plays out for a long period of time. And hopefully we'll get some field trials that will be informative. Unfortunately, we are close to time. So I'm going to have to stop us here, apologize to all of the questions that still remain, recognize that if you have ideas for future webinars, please send them along to Francois. I want to take this time now to thank our panel members for their very insightful comments, for taking time from their days to help the community better understand some of the challenges we face. We know that respiratory viruses are tricky entities. Jeff and I have both done research on influenza and have learned to respect the virus. But let's also remember to respect each other. We have self-regarding and other regarding obligations. All of us are in this together. It's an all of society response. And as the Director General of the World Health Organization likes to point out, this is a time for both local and global solidarity. So thank you one and all. Thank you panelists. It's been a great pleasure. And I hope we'll have another webinar in the very near future. Everyone keep safe, keep well, wash your hands, maintain your physical distance, and keep sane. Thank you.
Thank you.
Bye.